Hi, good evening, everyone. So I hope my slides are visible, and I think we can take it from there. Uh, what we are going to discussing is the management of metastatic CRPC, and I think it's interesting in the way we are developing. This thing is developed because I think for quite a lot of time, I think since 2019, we did not have anything new which came up into the market, which came up into the clinical scenario, and now. What we have is a number of 4-5 drugs which are there other than, including the Keytruda or pembrolizumab, if you think of it in MSI high subgroup. Anyway, moving forward, so we have obviously DOSI and Abira in HSPC setting. And then once you have a CRPC, it can be a mCRPC, which is non-metastatic CRPC, which you just spoke about. And then there is Abira, Enza, and then there's a DOSI and there's a Kabazi. And then obviously we have olaparib, and then there is a Ciplicil T, and then there is pembrolizumab for MSI high, which is a tumor agnostic indication. So I think I'll start with I think that the question here is not what is the first line of preferred drug in NMCRPC. What I would start is what is your first preferred line of therapy in metastatic HSPC? I think that's where the story possibly would begin. So Dr. Ankit, what is your drug of choice when you have a... So we're obviously talking about somebody who had a high volume disease. I'm not talking about somebody who has a low volume disease. Somebody who has a high volume disease, do you prefer docetaxel or do you prefer the hormonal analogs?
Hello, good evening, sir. So basically, sir, the decision is not that simple. We usually take a lot of factors into consideration, like age of the patient, performance status, any comorbids, and all these things helps us in deciding the first line therapy in hormone sensitive prostate cancer. But usually my personal choice is usually docetaxel, because that is a limited drug. We have to give only 6 cycles, and most of our patient doesn't prefer like long-term therapy in terms when we talk of novel therapies.
That's pretty interesting, because it's what I generally find is it's very difficult to convince a walking talking patient for chemotherapy, and then Abira, it doesn't come as a higher cost as compared to the Western countries in our country. Does everybody has a similar practice? Dr. Samir, do you have a similar practice? Do you prefer? So we are talking about HSPC, not CRPC. So the first drug which you end up using in a prostate cancer, is it docetaxel or Abira or Enzyme? Whatever your preference is.
Yeah, Dr. Bhuvan.
Yeah, please tell me.
No, Dr. Samir, please. Sorry.
Yeah. So anyway, probably I am the only odd one out in the audience. I'm a radiation oncologist and a hardcore one. And okay. I do not practice chemo and hormones. Yes, of course. But I usually, when we see these patients, in fact, we refer them to our medical oncologist for whatever best they feel.
Perfect. So I think, let me ask the other 3 medical oncologists. I hope Dr. Bhavesh, I hope you are a medical oncologist, and I'm sorry if I'm asking you this, but then what is your practice? And then I'll move to Rakesh and Dr. C.
So in HSPC, we would stick to the abiraterone, and I think we'll keep docetaxel for later usage when the patient goes to a stage where it is CRPC.
So, Dr. Rakesh and Dr. Asim, one word answer. Dosi, Abira?
Sir, basically depend on the symptomatology and burden of disease. If symptoms are very bothersome, then I would, and PSA is good, then I would prefer docetaxel. Otherwise, low volume disease, not that symptomatic, abiraterone.
That's interesting. Generally, because once you use Abira, I think possibly in a HSPC setting, it's very rare for a patient to have excessive symptoms, because it's a... Anyway, so Dr. Asim, what is your practice to it?
So usually we decide disease load and where is the disease. If patient has a lot of soft tissue disease, lymph node burden is there, visceral involvement is there, they might not be so symptomatic. And if the PS is good, we start with the docetaxel. If the patient has a lot of bone disease and other visceral part is not involved, and patient is in the, like say, borderline GC or something, we go with the abiraterone. So this
Perfect.
is my take on
fair
this.
enough. So as I understand, the panel is divided between Abira first or a DOSI first, and I also understand that once the patient moves on to the mCRPC setting, the other agent will become the first agent, right? Is it different with anybody else? As in, if you're given dosi first, the abira becomes the first drug, and if you're given abira first, the dosi becomes the first drug. Is it what everybody's practice is?
This is the same we all practice.
Yes, sir.
Perfect. So I think we understand that how so when you look at the evolution of taxanes in CRPC setting, there is obviously a evolution there, and then there was a clear evidence, I think in 2010 or 2020, I think this is 2012 if I'm not wrong, when dosi had a superior quality of life and OS as compared to mitoxantrone, be it be weekly or be it be 3 weekly, and I think that's what the standard of care became. And then came the AA302 trial, and then there was a ENZA trial, which again in a second line setting, it became the alternative drugs if you had once you had progressed post chemotherapy. So is it, I'm just asking it for, if you're given abira, if you're given dosi first, do you have a preference to use ENZA, or I think do you all prefer abira first? So let me start with Dr. Asim. Would you ever prefer, or is there a particular subset of patients who prefer ENZA in such patients? Hello, Dr. Ankit, can you listen? Can you hear me?
Hello.
Yeah, can you hear me?
Sorry, I have muted. So again, I will speak. So you asked me, I would prefer abiraterone or enzalutamide. So my take is usually I prefer abiraterone over enzalutamide, because sometimes patients are in GC, lower GC and all, PS is not good. Enzalutamide causes fatigue, which is very difficult to handle by the patient and relative also. And it has CNS symptoms also, which is more troublesome than abiraterone. So, and handling of abiraterone is easy for the clinician also. Effect is almost same. So I would prefer abiraterone over the enzalutamide.
Fair enough. Is there anybody who would prefer post-dosi ENZA over abira? I hope the statement is clear. So, Dr. Ankit, Dr. Bhavesh, what is your take on it? Would you prefer?
So, as Dr. Asim mentioned, most of the patient will go for abiraterone. But if I have to choose or I speak about enzalutamide, it will be patient who would not be a candidate where I want to use steroids. That would be my choice. Enzalutamide would be the choice. And those patients who are having too much of cardiovascular issues, again, enzalutamide will be my choice rather than abiraterone.
So it's interesting how you raise the question of steroids, but essentially we are replacing the physiological steroids. When you're using abiraterone, all you're doing is you're replacing the physiological component to it, right? Essentially what you're saying is, I would make the patient steroid deprive, but then essentially it's 5 milligram in a metastatic setting, right? Isn't it an mCRPC setting, right?
So this is for patients who are like brittle diabetes. So we don't want to push them further. Even 10 milligram of steroid may lose the control.
Perfect. So Dr. Rakesh, do you have a similar practice or is it different?
I think, sir, I will prefer abiraterone over enzalutamide, as we have seen. If you use enzalutamide first and patient progress on enzalutamide, abiraterone might be not that effective. Rather than in reverse case, if we have used abiraterone, then in third line enzalutamide can still be effective. So yes,
perfect.
I will prefer abiraterone, and in later lines I will prefer enzalutamide.
So I think what percentage of your patients receive NHA, I think it's very clear. It precisely depends upon what you have used in the hormone sensitive setting. So moving from there, what is the drug of choice of the patient in second line? I think that's where the entire the scratching of the head starts. That what now? Possibly because as a medical oncologist, we are almost it's a very programmed thought that you start with dosi, you move to ENZA, you start with ENZA, you start to move to dosi. After that, what you do is where the interesting thing goes on. So Dr. Ankit, I'll start from the beginning. Dr. Ankit, what is your take on it?
Yes, sir. So if the burden of the disease is high and patient is symptomatic, then cabazitaxel is one option. But otherwise, if burden of the disease and symptoms are not that much, then we prefer second line hormonal therapy. Like if we have used Abira, we can shift to enzalutamide, and if previously used enzalutamide, then Epletron is one option.
Just a minute. So, does anybody has a different practice? Do you done? So, because once the CARD trial came in, there was and there is obviously an evidence of benefit of using Kabazi, or there is an improved survival with Kabazi over the second line hormonal agent. Do you all prefer to go from Abira to Enza, or anybody prefer going from, or in the second line, does anybody prefer Kabazi over the next generation of NHA? So, Dr. Sameer, I'll come back to you for the genetic testing, I think, because most of our questions till then are going to be obviously about the agents. Yeah. So, Dr. Bhavesh, Rakesh, and Asim, do any of you prefer using Kabazi over Enza?
So, Bhavesh here. I would like to use Cabazitaxel, especially when I am sure that I am going to use Cabazitaxel for this patient or any kind of chemotherapy now, because down the line, this patient are going to go down on their PS. So probably this will be the best time to use Cabazitaxel. And I'll keep the hormonal therapy maybe later.
Dr. Rakesh, your practice?
Sir, depends on the performance status. Yes, if it is good, then Cabazitaxel, otherwise enzalutamide.
Okay, and Dr. Asim, your practice?
So there are two options, like either we re-challenge with the docetaxel if earlier response was very good and DFI was good, or if patient is preserved or in well GC, and the other similar option is from Cabazitaxel if patient can tolerate that. If not, then enzalutamide. Okay. So challenging is also an option. You can choose other taxans, and if not, then you can go with the enzalutamide.
Fair enough. So I think Dr. Roshni has also joined. Welcome, Dr. Roshni, and I'm sorry for asking. You're a medical oncologist, right?
She's a medical oncologist.
Yes. Sorry.
Sorry and thank you. I couldn't attend.
So we are discussing. So as a part of the, as part of the panel or as part of the process, we have reached on the second line metastatic CRPC. That's where we have reached as of now. And let me ask you this question, or let me ask let me ask all my panelists, how many of you have moved on to the PIS1 regimen? And so, Dr. Roshni, have you tried PIS1?
In my practice, not yet. No, I have not tried PIS1 regimen in my patients in the second line treatment. I generally, I concur with the other panelists. I generally use, based on the burden of disease, either Cabazitaxel or newer generation anti-androgens.
So, Rakesh, have you started using dual to begin with?
No, sir. Actually, only PFS data is available. I think I would
there
like.
There is OS data also. Yeah? There is, which the median was not reached. I think, if I'm not wrong, it has been quite some time. Median was not reached for the OS, and it was something like 54, 55 months for the standard of care. If I'm not wrong, I don't know. Possibly, this is what I remember reading last. So, anybody of you, Dr. Asim, Dr. Bhavesh, Dr. Ankit, have you tried PIS1 to begin with? Because that what will make it. Fair enough.
No, never.
Great. So I think I thought of trying it from one, but then the patient refused. But then I kind of knew my colleagues who were doing it. We were rather having a discussion other day in one of our meetings. But yeah, it seems like an interesting disease, interesting way to treat. And obviously the only problem is that sequencing. It obviously kills off the sequencing a lot. So we have data which suggests that, I think we'll move on to this one. Yeah. So it was, so there is data from the CARD trial, which is there. And I think the CARD trial is one which puts Kabazi versus Abira Enza in a metastatic prostate cancer, a patient who has progressed a DOSI and who has progressed on one of the HAs. There is an improvement in the radiological PFS, which is around 8 months versus 3 months. And improvement in the overall survival also, which is around 2.5 months, which, and I do understand that, cabazitaxel, when it comes to it, it's a difficult drug to tolerate. And there's a lot of challenges in terms of the dosage. We obviously, since 2017, I think 20 milligram per meter square has been approved dosage. Obviously, the adverse effect still is a challenge. So, ideal drug sequencing in mCRPC, as you have all mentioned, there are a lot of issues to it. There is a PSA doubling time to it, and then there is symptomatic versus asymptomatic disease responses, and what is the disease-free interval which you have had. Can you re-challenge with one other drug? What is the volume of the disease? So it helps you decide whether you want to use a chemotherapy versus a NHA upfront. How much is the visceral disease? I think it's all been touched upon. It's all been discussed. And then there are other markers to it, which we've already discussed. So there is this obviously meta-analysis which was presented in 2017, in which post-dosy setting of Abira and Enza. Yes, there is a trial which says that if you sequence Abira after Enza, the response is not as much as or as great as if you sequence Enza after Abira. And I do concur with that, and also because of the toxicity profile of it, we all understand that Abira is a easier drug to tolerate and it's easier to give. And Enza has obviously the issue of fatigue and the diarrheas, and 160 milligram becomes difficult. You have to move down to 120. Then I think 2% of the people, there were seizures also. However, in this meta-analysis, there is a PSA progression. There is a numerical advantage of using Enza, which provides you a PSA advantage in terms of the longer time to progression for PSA and a better radiological PFS. However, it's not a direct comparison. There are obviously caveats to it. The sequencing has been a challenge, and I think none of us are wrong when we try to sequence Abira followed by Enza or Abira followed by Kabazi followed by Enza. It's all on the clinical settings. So I think moving forward, let's move on to the patients. So we all understand most of our patients before they. So let me ask this. How many of you try to bring in olaparib before you give a second line NHA? So I'm asking this in terms of when do you do your germline testing? When do you do your tissue testing for mCRPC? Dr. Roshni, when do you plan to do? When do you bring in the tissue testing for it, for the presence of HRR genes?
I usually use I test for HRR genes in patients who have started the chemotherapy, because even if the patient responds with the chemotherapy, it's only finite number of cycles I will be able to use considering the toxicities. So eventually, when the patient does respond and I have given the around 6 to 8 cycles or maximum 10 cycles of chemotherapy, that is when I would like to put the patient on maintenance using PARP inhibitors. So that is the usual time when patient progresses after first line. I generally test.
So you're talking about HSPC setting or CRPC setting? So what I'm asking is the chemo in the HSPC setting or
resistance.
Okay, so what you're saying is the moment the patient. Yeah, sorry for interrupting. Please go ahead.
Yeah, I'm talking.
Okay, so I think what we're obviously having a bit of network issue with her, but then what I understand is the moment the patient touches the CRPC horizon of prostate cancer, is that when most of us probably will do a HRR testing. Do everybody agree, Dr. Ankit? Is that your practice?
Sorry, sir. Can you please repeat? I missed there was signal issue.
Let me ask this to Dr. Sameer first, because I think he has been there for quite some time, and I possibly do not have questions for him rather. So, Dr. Sameer, in your clinical practice, when do you do the testing for HRR genes in a prostate cancer?
So yes, I believe once a patient is tagged CRPC, probably this is the right time when these testing should be done. If we go by the guidelines, I guess there are many situations where they recommend these testing, but probably in clinical practice, most of our patients, they undergo these testings when they are once they are diagnosed with CRPC.
I think
yeah.
And is there a particular time when you can you just 1 second? रियासत में एक मीटिंग के अंदर मैं थोड़ी देर में करता हूँ, अर्जेंट है मीटिंग, थोड़ी देर में 9 बजे बुलाते नहीं, सुन 11 बजे, 11, sorry. So the point is there a particular test which you do? Let me ask, let me go through the panel and ask Dr. Bhavesh, when do you do it?
So as most of us will do in practice, that if the patient is a patient who is going to go for PARP inhibitors, then as soon as the patient touches the CRPC line, you should better get it done. So we know when to use it and whether the patient is ready for that or not.
Fair enough. So Dr. Rakesh, when do you do it? I think you also agree with the same fact that you do it at the CRPC.
Yes, sir, I agree. Once the patient becomes CRPC, we should test for HRR as well as MSI testing and tumor mutational burden also to explore further options.
So would you prefer using olaparib before trying with the new second line NHA?
Sir,
ज़्यादा हो गया.
I'm
just generally asking.
To answer actually.
So because if you look at the trial data of the PROFOUND trial, I think it's been used, right? You are obviously challenging it to. So once the patient has progressed in one of the NHAs, you're using it then, right? Yes. So what I'm asking, in clinical practice, are we preferring to use a PARP inhibitor before a second NHA or after the second NHA?
We prefer usually after second NHA.
Dr. Asim, what is your practice?
So earlier we used to do at the recurrent setting when the CRPC line has touched, but now gradually we are shifting towards testing the this BRCA and MSI testing early. And
early as in?
I do, yes.
We'll early as in what, at what time?
Early means once the patient present to us and we receive the blocks. Because later on what happens is the blocks are older, the archival is very tough, and repeat biopsy is not possible. So this is the major issue. So we want to do upfront. And when we start the olaparib, now we are shifting our practice to just finishing the docetaxel and then maintain with the olaparib if they are the BRCA positive.
Do we have data for maintenance olaparib in prostate CRPC setting? I'm just asking, possibly maybe wrong. Is AstraZeneca team there? Do we have data for olaparib maintenance? I think let's are my medical oncology colleagues aware of any data for olaparib maintenance? Dr. Rakesh? I think I lost you. Anyway, so moving forward, as most of us agree that there should be a genetic testing. There should be a genetic testing which should be done, and I think most of us end up doing it at the time when once the patient is diagnosed in metastatic CRPC. However, doing it early, as Dr. Asim said, is not a wrong idea at all. So there are obviously a number of DNA repair genes or homologous recombination repair genes which can be there, which can be tested for. And I think what I prefer is in Indian setting, what I generally end up preferring is a hereditary multi-gene cancer panel with reflex MLPA. I think that's for the germline testing. Otherwise, for a tissue testing, I think I generally send it for a entire HRR panel. So I think we have already discussed this point that we end up preferring doing the test at the moment it is diagnosed with a metastatic CRPC setting. So I think this is what is recommended also, that you can obviously, once you have a patient who has a very high or regional or metastatic, it is recommended that you test for the BRCA and or basically you test for the germline and as well as MSI. And if you look at the time profile of it, tumor tissue may be available for the surgery, but at this present, there is no role of HRR testing in the initial part of it. I think the moment the patient becomes a first-line metastatic CRPC, there is a strong consideration of checking for the BRCA testing or for a HRR testing along with MSI or TMB. So coming to it, what would be the preferred tissue? I think the challenge which most of us end up having with the prostate is that once the prostate is progressing, obviously if you have a visceral site to biopsy, it's not an issue at all. However, if you do not have a visceral site to biopsy, as most of the times may end up happening in a prostate cancer, biopsying from a sclerotic bone mets is a challenge, and which is a challenge. So I think what I do in my clinical practice is obviously try to get an archival tissue or do a germline testing instead if I do not have a soft tissue to biopsy. So Dr. Ankit, what is your practice to it in terms of the tissue of the biopsy to test it?
So I agree with you, sir, that doing a fresh biopsy at metastasis is very difficult, especially with bone lesions, sclerotic. So as of now, I have done it for only 1 or 2 patients only, and I have used the archival tissue only.
Okay, fine. Dr. Samir, at your press, if once it comes to your patient, such a patient comes to you, what would be your
at our institute also we usually prefer from the previous samples we have in our bank.
Does anybody of you have tried doing a germline testing if the patient does not have a tissue?
Yes, we tried with you can see the blood or saliva. We can do that because generally in mCRPC setting, the patient's slide and blocks are very, very old.
Yeah.
So we tried and we are getting results also. So we can send the blood sample or maybe the saliva sample, whichever they accept the lab, we can send that, and we are sending.
Fair enough. So in the trial, obviously most of the tissue were archived tissue, as it happens in the clinical practice. And what was interesting to see is that the prevalence of HRR genes were higher in the metastatic tumors and not in the primary tumors. So that's what it was interesting to see that, and possibly because of the it's because of the archival tissue has a problem of DNA extraction, and I think this is possibly the reason that the DNA extraction was higher and you could pick up the HRR genes higher in those. So I think what would be the preferred algorithm for HRR testing? We are possibly clear that we should, if possible, try to do a recent biopsy. If or not, try from archival tissue. But I think most of us end up having this problem with the archival tissue is that the tissue is not sufficient. Possibly the patient has shifted the hospitals, getting the block from the old hospital is a problem. So I think there are multiple problems when it comes to it. The presence of a germline tissue. That is always the option. And
my apologies, sir. You are left with just 1 minute to conclude your panel discussion.
So I think I am there I'm almost at the end of it. So we all understand that if you have a HRR gene, what you do is BRCA1 and BRCA2 and ATM is where the CDQ, that's where the utilization of olaparib is best. And I think we end up there are 2-3 patients of mine who are on olaparib for such a patient like that. And I think it's obviously there are adverse effects to it. The problem is that at the time when you're using olaparib, most of these patients have undergone a multiple number of therapies. Obviously the marrow reserve is less, so they end up having a lot more hematological adverse effects as compared to a standard ovarian patient, if you would consider. I think that is from my side. I'll just take 1 more minute from everybody. Have you tried olaparib in prostate cancer, and what are the challenges which you end up facing specifically in prostate cancers? So Dr. Ankit, I'll start with you. Do you face any specific challenge using olaparib in prostate cancer?
So sir, I have not yet used in prostate as such, but I think challenges will be same as we are facing in ovary.
Fair enough. So my only thing is, the problem with the prostate is they're slightly old. You have given 3-4 lines of therapy before. I think that's a problem.
More fatigue and
so Dr. Bhavesh, any specific problems to prostate olaparib?
So Dr. Bhuvan Bhavesh has left.
Okay, so I think we'll Dr. Asim just answer this question and then we'll move to Rakesh and then we'll finish it off.
Problem is with only diarrhea and the caring of the patient. This is the only problem with olaparib.
So Rakesh, any specific problems to olaparib in prostate? I think he's also there. Anyway, thank you all for being for active participation.
Yeah, thank you, Dr. Bhuvan. And it was a wonderful discussion, and you enlightened a very different aspect of the prostate cancer in mCRPC. And thank you very much for your presentations.